We had a great opportunity to visit with a number of very interesting people at the South Dakota State Medical Association meeting. Now you get to hear them as well.
Funding for OnCall is provided in part by
Avera is a proud sponsor of OnCall on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support OnCall, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for OnCall is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
We had a great opportunity to visit with a number of very interesting people at the South Dakota State Medical Association meeting. Now you get to hear them as well. During the annual meeting, we sat down with 12 doctors from across the state of South Dakota and Barbara Smith, the CEO of the South Dakota State Medical Association. The topics were as varied as the guests. So sit back and enjoy these candid conversations.
Well, the value for the patient for the South Dakota State Medical Association is that our organization represents 2,000 physicians, residents, and medical students practicing and studying in the state of South Dakota who will be future physicians. Our role is advocacy for physicians and their patients, both at the national level and at the state level. And we work on various important issues that are health policy related, healthcare reform, the cost of healthcare, the quality. We have a number of projects that are specifically related to those areas that we work on in collaboration with the state government and with other collaborating partners to improve the quality of care and keep the costs as low as possible for the patient. We're also a resource for patients who might have concerns or complaints or questions about their health care. We provide information, educational materials, but also just directing them to the right place if they are unfamiliar with where they can go and find information or what to do with a concern they have. So those are some of the things I think that are of value to the patients of South Dakota. Well, one of the most exciting things I think our organization is involved in right now is we initiated a South Dakota Quality Collaborative several years ago, and that particular project that we're working on is looking at data and looking at how we can improve the quality of care in South Dakota hospitals and ambulatory settings. That's a partnership that we have with the South Dakota Association of Healthcare Organizations, which is our hospital association. And so we're really interested in looking at the outcomes of care, but also the cost of health care. And those two things really equal value. You know, what is the patient ultimately receiving for the value of the health care that they receive. And we hope that as that project develops, that we have more information that we're able to share with the public so they can make good decisions about the health care that they receive, and that we also work with the provider community with bringing them all together. Instead of in many businesses, we're in a competitive situation, and we're interested in bridging the competition that exists so that we're all working together on improving quality, sharing best practices, and what works in one facility will be helpful to other facilities, and that we can work together on those kinds of things and learn from one another and share our best practices and improve the quality and the value of the healthcare that is delivered in South Dakota. In South Dakota, we have among the highest quality care and the lowest cost in the country. And so we know what we're doing is right, and we have excellent medical resources in South Dakota, physicians as well as hospitals. And we think that because we're able to work more collaboratively together here in our state, we have a need and an interest to do that and share resources, that we just want to continue to work in that regard and continue to be a resource for all of our providers. So that's probably one of the most exciting things I think we're working on.
Well, there's a couple different things that cause healthcare costs to increase. One is the cost of medications, the research and development that costs the public and gets passed on from the companies to the patients to have the new medications to deal with the advances in treatment. There's also costs in imaging. It costs more to run CAT scans and MRIs, and everyone wants the best study and accurate information. Combine that with health information technology, electronic medical records, and the cost for private physician practices to implement those guidelines by Medicare and Medicaid. Those are basic costs. In private practice, it's the cost of overhead and running your practice. Liability insurance for physicians is also a contributing factor. Malpractice insurance. Those are the main costs associated with that. I think physicians fear that potentially they may be judged based on different changes in the healthcare plan on the way they evaluate and allocate resources. Accountable care organizations may be a structure that suggests providing allocation of care in limited fashion based on evidence-based studies. So if a CAT scan says you don't, or if a study says you don't need a CAT scan to prove your diagnosis, your physician may say, I'm not going to order that, and that's actually good evidence-based medicine. And if an organization can put that together, an accountable care organization, that will decrease costs. But in a way that may limit access to some testing that patients may want. But the counter-argument is it's based on science. And then this goes to the concept of the medical home. If I come full circle, I'd love to be in a medical home where I could have a team of 6 people. I could have myself, my physician assistant, my 2 nurses, my health coach, and we could sit down with our 2,000 patients in our group, and then I could manage those patients, and every week we would sit down. Who are our trouble patients? These 3 people were in the ER. Well, why were they in the ER? Well, they didn't get their medications, or they failed to get their durable medical equipment. Well, let's make sure we call those people in the next week or 2 and make sure we get them in a priority slot. So physicians change the way they think, and still where they're starting to manage a group of patients instead of saying, let's just get 20 people in today, because my quota is to see 20 people. And if I get 20 people, I pay my overhead, and I can do all I need to maintain the ability to practice medicine. In rural communities where a high percentage of Medicaid, if I see 15 Medicaid patients out of 20, I can't keep my business open. But if the payment model changes to where we go into the medical home, and now I'm paid for the quality care of those patients, then maybe that will give better health care and outcomes. It sounds like how you'd want to be taken care of. And that's actually how patients want us to take care of them. They want me to be concerned about their health care problems, and we are. I'm very sad when a patient has a bad outcome. I'm very sad when I can't get that diabetic to goal. I want that hemoglobin A1C less than 8 or less than 7, and I know they'll have a better outcome if I can do that, but I can only do so much. There's patient responsibility. They need to push themselves away from the table. They need to exercise. They need to watch what they eat, all the things that they know how to do. But if you incorporate medicine as a team and you give reasonable goals, and then you make those appointments, you make your yearly annual exam, you make your follow-up appointments, the chances of having better outcomes is higher.
There have been a number of issues related to the cost of health care, and I think some solutions have been brought forward. In my practice of medicine, I'm background's a family physician, practiced in a small town for about 15 years, and I think cost is always in the front of your mind, but folks are talking about healthcare reform, ACOs, bundled payments, all kinds of options. I think the real challenge is how do we move from working with volume-based healthcare to change it to outcomes-based healthcare, and by that I mean how are we going to manage that from where you're used to seeing patients every 15 minutes to move into an environment where you want to take care of chronic disease. I think some of the solutions we're looking at for cost around the country with ACOs, bundled payment, I think there's certainly options. There's still a lot of items in flux right now nationally. Supreme Court is still out. Where are we at with healthcare reform? But I think the bottom line is how do we move from volume-based medical care and move to quality-based outcomes, whether you do it with bundled payment, ACOs, or the like. I think you have to figure out how to manage that flip, and that'll get us along the road where we need to be. To manage that flip, you have to look at the physician practices. You also have the insurance industry where they're used to paying on volume, not outcomes. The medical communities are used to managing patients on volumes, not necessarily outcomes. And to time all that and transition that, I think, is an incredible challenge. I think folks have talked about HMOs, but ultimately I think it's a path that moves back towards capitation. It's kind of the crawl, walk, run scenario, and I think you start down this path with the ultimate goal is probably a model similar to what used to be known as capitation.
I think what a lot of people are thinking about in terms of change these days is in terms of the Affordable Care Act and healthcare reform and all of that that's going on right now. And who knows what all is going to happen as a result of all of that. I think some things are inevitable. The way that healthcare is being paid for is changing and will continue to change. The old world of just fee for service is likely to be replaced in some way by payment for quality, payment for doing the right thing, bundled payments for episodes of care, which would include hospitals and doctors and other folks all getting paid out of one lump sum. Those kinds of things. How that's all going to fall out, I don't know. I think the only thing that's certain is that it's going to change. Another big change that we've seen is the movement to hospital medicine. That is, the specialists who deal with inpatient medicine and then other folks that do the outpatient medicine. And so we have hospitalists now that we didn't have 5 and 10 years ago. And those folks are handling a lot of what happens inside of the hospital. And the primary care physicians in particular are kind of moving away from the hospital and really focusing on doing the outpatient thing and doing that very well, getting that organized and structured. And that is a more structured kind of existence. Getting away from going to the hospital in the morning and then going to the office all day and then going to the hospital in the evenings again to finish rounds, or getting called out of the office during the middle of the day to see a patient in the hospital. That was a pretty disruptive existence. And I think a lot of the younger physicians that are coming out, particularly in primary care, don't see the benefit of that. And they really want to have a more structured existence where they go to work in the morning, they're able to get through their office day, and then not have the responsibilities of being on call at night or having to go make rounds in the hospital, that sort of thing. Plus, hospital medicine is becoming more highly specialized. People are sicker in the hospitals now. They need a lot of attention. They need things to happen frequently and in a very complex way. And so decisions have to be made about their care multiple times during the day. If you're in your office, you really can't do that. The hospital stays are so short anymore that the average length of stay has come down from probably 6 days down into the 4 or sometimes even less than 4 days on the average. And that's a lot to happen for a very sick person over a short period of time. So it's just getting to be a lot more complex in the hospital. People who specialize in inpatient medicines and are there in the hospital 24/7 can manage that much more efficiently and effectively than somebody who's trying to do both worlds. Likewise, people who specialize in outpatient medicine can do that much more efficiently and effectively if they're not drawn away into the hospital or having to worry about making rounds before and after their clinic.
Hospital readmissions refers to a patient being admitted to the hospital and then being discharged and readmitted within 30 days. The idea is to take care of patients in such a way that once they are dismissed from the hospital, they have the education and ability to take care of themselves either at home or the long-term care facility that they return to, so that readmission within 30 days isn't required. At the present time, the federal government is quite concerned with the fact that nationally approximately 22% of Medicare patients that are hospitalized are readmitted within 30 days, and this occurs at a cost of around $7 billion a year to the Medicare Trust Fund. At Tri-States in 2010, as one of our quality projects, we developed what was called a hospital-to-home program that was carried out at the Avera Heart Hospital and McKinnon Hospital in Sioux Falls. And what we did was develop a protocol in which a patient was identified as soon as they got into the hospital. We did it on congestive heart failure. So we identified that they had congestive heart failure as soon as they were admitted to the hospital, and a transitional care coordinator was assigned to them immediately and started with education about their disease and about their medications, and that continued during their hospitalization. Once they were dismissed from the hospital, the transitional care coordinator then visited them in their home within 24 hours. We supplied them with medication dispensing units so that they could be sure and get their medications correctly. We provided them with a scale so they could keep track of their weight. We surveyed their home to see if they were capable of being home alone and whether they needed home health assistance or hospice or palliative care assistance. Then we also made sure they had an appointment to see their primary care provider within 1 week of dismissal. And with this, and then after that time, we contacted them on a weekly basis to see how they were doing and answer any questions they had. They also had access to our transitional coordinator 24 hours a day, 7 days a week for 30 days. And the results that we got was the readmission rate for congestive heart failure alone dropped from 22% down to 5%. So it made a significant difference. Generally speaking, the hospital stay was not affected at all. It was just the fact that we had the support of the physicians. The physicians told their patients that they would be put into this program, and they were electively signed up for it, but the physicians encouraged their patients to get into the program, and the program just amounted to education on their disease and then follow up at home, rather than giving them all their instructions at the hospital, patting them on the back and saying good luck. We went out to their home and followed them for 30 days to make sure that they had the resources they needed and the education they needed to take care of their disease.
The South Dakota Prescription Drug Monitoring Program is a new program that is being implemented in South Dakota, which tracks the controlled drug prescriptions that are dispensed to South Dakota patients. These drugs include pain medications, stimulants, anti-anxiety agents, typically drugs that have been determined by the DEA, Drug Enforcement Administration, with a higher risk or potential for addiction or abuse. The initial part of it is that we have to get the prescription information from pharmacies that dispense the prescriptions to patients. And that prescription information comes from pharmacies located in South Dakota that are licensed by the Board of Pharmacy that fill prescriptions. It also includes pharmacies outside of South Dakota, mail order pharmacies that mail prescriptions to South Dakota patients. And we also have prescription data from our Indian Health Service facilities in South Dakota. It is a complicated, IT type of process, but pharmacies right now all have sophisticated computer systems. If you go in and get a prescription filled at your pharmacy, most likely it's paid for under an insurance plan. So that data is already going into a hub with all of the appropriate information that we need for our program. So the data is already there in a format that's easily then downloaded into the system that we use. Pharmacies don't have to do anything extra or different when they fill or dispense that prescription. The data we need is already captured as part of their normal process. It's only drugs that have been designated by the Drug Enforcement Administration as controlled substances.
Right. So
antibiotics, blood pressure meds are not included in the database. The purpose of our program is just to collect the data and to have it available to practitioners, to doctors, pharmacists, physician's assistants, people that either prescribe or dispense drugs. It's up to their professional judgment to determine when they learn the information of what the patient's history is on how they're going to use it to provide better care for the patient. Across the country, there's been many stories written about what we call doctor shoppers that go to multiple doctors either to overuse the medications for themselves or to sell it and to profit from that and to get more people addicted and in trouble. We started data collection from pharmacies back in December of 2011. And then we asked those pharmacies if their software system could do it to submit data back to July 1 of 2011. And so we've been collecting data now for about 6 months and then back to almost a year. In our database, as of a couple of days ago, we have a little over 400,000 prescriptions from calendar year 2011, July 1st to the end of the year. And now we have over 4,000 prescriptions for 2012. So we're over 800,000 prescriptions in the database. In order for a physician to get that information, the thing that they need to do is, first of all, they have to submit a request that they can do online to our office, indicating their DEA number, which is a federal number that authorizes them to prescribe controlled drugs, their South Dakota license number. They complete this form online, they read the rules, and of course there are rules on how this is protected health information. They need to agree that they will only do queries on patients that they are serving, and that the information is just like any other health information. They have to guard it, see that it doesn't fall into the wrong hands. Then they sign the form, send it to us. We validate their license standing with their licensing board. If they're in good standing with the licensing board, then we approve them for online access. They get an email message back that lets them finish setting up their account, and then after that, they can go into the website, enter a patient's name and birthday, and literally within seconds, get a report that shows these controlled drug prescriptions that are in the database provided to that patient. There are many, chronic conditions, back pain and other things, where patients need pain medication. And while these drugs are dangerous, in some cases they're safer than some of the over-the-counter products if they're overused. So it's all about, helping patients get what they need, and then maybe stopping that very small, percentage of patients that are misusing or abusing.
A lot of times, especially where I live out in the central part of the state, people like to get out and about in the fall because it's hunting season. We hunt a lot of upland game. We're out there in the fields walking for pheasants, walking for grouse. And then when deer season comes, we're out crawling around up and down the river breaks, chasing after those wily animals. What's important from men's health standpoint is that you realize that when you get out there in those fields and you're doing that hunting, that you're putting quite a stress on your entire body, most importantly your heart. You should therefore take time and energy and effort and plan ahead and get yourself in the proper physical shape before you go out there to do that. We all hear stories about men that are out hunting. It's usually about men and not about women. Somebody goes down out in the middle of the field and then they have to haul them in, and sometimes there's a very bad outcome. It's usually related to having a heart attack. Your job as a hunter, your job as a father, your job as a spouse is to make sure that you're in proper physical conditioning before you ever get out there. The easiest thing to do is to think ahead, make the decision, am I going to go hunting or not this fall? And if that's the case, I better get myself in better shape. Simply start walking, start doing that now. It's almost June, hunting season is not that far away. Go for a 20-minute walk every day. When that gets boring, increase it to 30. Get it up to 45 minutes a day. Do that every single day. That will help tremendously in lessening the chance of something bad like that happening in hunting season. If you have other medical conditions that you take medications for and are under the care of a physician for, make sure that those are well controlled prior to getting out into the field. But the most important part is to think ahead, plan ahead, much like you get your gun ready for hunting or your fishing stuff ready for going after walleyes. Get your body in shape for getting out there in the field. Most of the time when you're out hunting, you're out in the middle of nowhere. And even if you have a cell phone, you're going to be quite a ways away from emergency medical care and facilities to take care of that as well. So those are nice, but it's more about prevention than it is about taking care of the disaster when it occurs. Part of advice that I give anybody who's coming in for anything other than something simple like a cold is to ask them about their exercise, whether they do it or not. If they don't, how they can get started, and if they do, I congratulate them and tell them to keep it going. And the other part of that is to set an example. I mean, if your doctor's fat and out of shape and smokes cigars all the time, and you're not going to listen to him when he talks to you about exercise. So you have to walk the walk so that you can talk the talk and people will believe you. Exercise is a tremendous way to allow yourself to be healthier longer that does not involve doctor visits. It doesn't involve medications. It doesn't involve medication side effects, and it's pretty cheap. So yes, we're a sedentary society, and we're becoming more sedentary all the time. It's the responsibility of people as citizens, and more importantly as patients, to take good care of yourself. Take as good care of yourself as you do of your expensive car or your expensive home, because your body's more expensive than either.
People usually come in, oftentimes primarily for respiratory problems because they're so symptomatic. The most common one, without question, is coughing. Coughing just annoys people, and they feel that it's abnormal, of course. But there's also other subtle lung symptoms that you don't think about. For instance, shortness of breath with gentle exertion. I just walked up a flight of stairs and I'm so short of breath. That doesn't seem right, doctor. Or another one is I awoke in the middle of the night and I'm short of breath. Why am I short of breath when I'm sleeping? Things like that. And so we always probe those sort of questions. The other thing that we see really frequently is, often in younger people, is wheezing. The fact that I can actually audibly hear my child wheezing, or that with minimal exercise I'm just really short of breath and wheezing. Well, we worry about just routine asthma. It's not routine, it's asthma that we see oftentimes in young people. And then we see it again as people get into chronic obstructive pulmonary disease and have an awful lot of wheezing. We can actively treat that, and it's a very dangerous thing, even deadly, totally left untreated. But we often are very able to aggressively turn that around, or at least affect it. It's amazing how many people now are still smoking and really desperately want to quit. And the answer is that there's a lot of things we can do for you. The primary thing is to make up your mind that you want to quit, start cutting down, use the South Dakota Quit line, which is incredibly effective. And then we have medication now, both nicotine replacement therapy and medications that really help people quit smoking. Smoking is really a thing of the past in our society, and we need to help people try to get beyond it. What we're really excited about is that the number of teenagers that are smoking in South Dakota has dropped by nearly half in the last 10 years, which is amazing. Those are people that hopefully will live out the rest of their life free from tobacco addiction and live a normal life. We're still concerned about the number of pregnant women in South Dakota that smoke, and that hasn't dropped as significantly, and that's an area that we're trying to actively have an impact. I think a lot of young women want to keep smoking to stay thin, and once they're pregnant, they're terribly addicted to it and just really have a real hard time quitting. It is, though, the key. If we can get young women to quit, then they'll have healthier babies. They won't smoke around their newborns. They'll have healthier infants, and maybe they can talk dad into quit smoking too. So getting that pregnant woman to quit smoking is an enormous key to improving the health of our young people. There's nicotine replacement therapy that really works well. There's a drug called Chantix and another one called Zyban. None of these are approved to be used during pregnancy, but nothing could be more dangerous than continuing to smoke. In approximately 2002, we were able to get a limited ban on tobacco use in the workplace, which was a major leap forward for South Dakota. But it still allowed us to smoke in bars and restaurants and in lots of other work areas. And then just in the last 2 or 3 years, we were able to get a much more complete ban of indoor tobacco use in almost everywhere. Bars and restaurants, and almost all workplaces now are smoke-free. This has really encouraged a lot of people to smoke. They just realize that you can't smoke at work, you can't smoke in a bar, you can't smoke in a restaurant, and it's made a huge difference in the number of people wanting to quit smoking.
Well, the most common dermatologic or skin problems that I see are really two, makes up about 80% of what the allergists see. The first one is called atopic dermatitis. Atopic dermatitis is a flat, very itchy rash seen primarily in children behind their knees and in the antecubital fossa, but sometimes can cover the entire body. It's flaky, it's quite pruritic or itchy. I mean, these kids itch all night long. And when it is dry out, the rash is much more of an issue than when it's moist out, so it has a winter prevalence. Now, atopic dermatitis is a part of what's called the allergic march. The child starts with atopic dermatitis and then kind of starts to have trouble with food-related illnesses. The atopic dermatitis gets worse, the food-related illnesses are noted, and then the food-related illnesses get better, and the atopic dermatitis starts to get better, and then they develop the hay fever, allergic rhinitis, and the asthma symptoms. So, and these are all mediated through a part of our immune system called IgE, which is kind of what the specialty of allergy is all about. And so that's the allergic rash that I see most often. And the dermatologists have shown that you're actually missing a specific protein called filaggrin, and the less of that you have, the itchier and more difficult it is to control, and the more irritating things like soap and chlorine and things like that are. So these kids, we don't use soap because it takes away what skin they've got or skin oils. We tend to soak them, get them out, grease them up, and treat them at night that way. Sometimes we give them some anti-itch stuff. It doesn't work real well, but mostly greasing them up makes a difference by compensating for that protein that's missing, which apparently as they get older becomes more apparent and comes under control. Now there are kids that don't get over it, so those kids represent a much more difficult problem, and they'll have to use topical steroids and other stronger medications. The second rash I see a lot of is called hives or urticaria. And urticaria also has with it swelling called angioedema. And the urticaria rash or the hive rash is primarily a rash of the immune system with some overlap with allergy. And the most common allergy overlap is the one where you take the penicillin and you get a big rash from that is hive-like. Now, penicillin also gives a rash that is red from head to toe and mildly itchy. And that one is really, I call it the penicillin rash because it's not an allergic rash. And those people probably can take penicillin again. It's more about an interaction of penicillin with the disease that you have. Hives are welts like giant mosquito bites. They're very itchy. They come and go. If they're very intense, they sometimes leave bruises. Now that gets to be a much more important rash because the ones that leave bruises, it gives a term called vasculitis, meaning I've got inflammation that's so intense it actually includes the blood vessels and the little red blood cells leak out, and that's what leaves the bruise. So that's a much more intense type of hive, and we actually start renaming it as it gets more intense. And hives that last less than 6 weeks are called acute hives. That's the most common thing I see. Most of the time does not require treatment, does require a history so we can figure out did you take some medicine or a food or something of that order that might have caused that. I would say 70% of the time the patient knows exactly what caused that problem. So that's a very short interview, and we treat that expecting it to go away with antihistamine and steroids at some time. The person that has hives over 6 weeks, he keeps hiving, keeps maybe having a little bruise, that's a whole different group. That requires a workup or evaluation, more for us to tell you how long is that rash going to last, and is this the window to some underlying problem like lupus or Crohn's disease or some more intense process. So 2 rashes. The first one is atopic dermatitis, associated primarily with allergic disease, with a little group of people that get atopic dermatitis that doesn't go away, and they have a different disease process missing this protein. And urticaria or hives, which is an immune issue. So those are the 2 most common types of dermatologic diseases that the allergist evaluates.
Well, the most common class of cancers I see are referred to as cutaneous malignancies. It's basically skin cancer. And there are several varieties that we deal with, but most of them are related to sun exposure to the skin throughout one's lifetime. It seems to be getting worse. There are a lot more people wearing a lot less. They're out in the sun for longer times during their lifetime. And so I hardly go through a week without treating at least one person with a skin malignancy. There are 2 common types. The most common is basal cell carcinoma. This is a low-grade malignancy, but it can be very aggressive locally. It's not likely to spread to distant sites. It does respond to radiation in certain occasions, but most often it's treated surgically. One of the most frequent places that it does occur, however, is on the face, and I think that's why plastic surgeons have been more involved in treatment of skin cancers than most other disciplines in surgery. We have had excisions of the entire midface for some of these more aggressive cancers, and that can be reconstructed with a series of flaps, tissue expanders, and sometimes we even resort to referring to dental facial prosthetists can actually create a sort of a mask for the ones that can't be reconstructed that looks quite natural, actually. Most of them are very minimal, and in the case of basal cell cancers, the earlier you treat them, the less problems they cause. If they're neglected, they can become a problem that's virtually untreatable, or treatable but not with very good results. More other common types of skin cancer include squamous cell carcinomas that are similar to basal cells in that they come from the skin, but they tend to be more aggressive. They can metastasize, although the true skin cancers rarely do. But if you, again, neglect those, they can be much more aggressive. And when you have other comorbidities like diabetes, immune problems, they are more likely to metastasize. They, again, in this part of the country, most frequently are found on the forearms, the upper trunk, and the face, because we do have very long days in the summer here, and people are out sometimes working, sometimes playing in the sun, and those are the areas that get the most exposure. Again, early treatment is important. Sometimes we see them as pre-malignant lesions, and can treat them sometimes without surgery or with a combination of surgery and topical chemotherapy, and get those resolved before they become a big reconstructive problem.
I have had quite a few patients with varicose veins. They usually come in and they're concerned because they're having pain in their legs, swelling in their legs, and wondering what caused them and what can they do about it. Usually varicose veins are hereditary, and so I usually ask, if they're family members, mother, father, typically somebody has varicose veins up the road, and as far as preventing them, you really can't do much about that. Wearing support hose is probably the most common thing that we recommend. Tight support hose helps prevent the pain of the varicose veins.
How does it do that?
By compressing them. If the veins are compressed, then the blood doesn't pool in them, and the varicose veins, the valves in the veins are not functioning properly, and so you get a column of blood instead of getting, if you've got frequent valves in your veins, then you've got a short pool of blood in your veins. But if the valves are not functioning, then you've got the more blood pressure in the veins, causing them to dilate and be uncomfortable. So if you wear support stockings, that compresses them and keeps the blood from having as much blood in that vein. There are surgical procedures for taking care of them as well. Lasers, tying them off, different methods of treating them besides the support hose. But if you live long enough, you're going to get more of them back. So ultimately, other veins will dilate, and you'll get a short-term improvement from these procedures, but usually not permanent.
people who are on their feet a lot, people that are standing all day in their type of vocation are bothered more by them than people who can put their feet up when they want to and take care of themselves better. Being overweight doesn't help them either.
Well, post-traumatic stress disorder diagnostically is one of our anxiety disorders, but everybody has heard about post-traumatic stress disorder as a result of the Iraq War and Afghanistan wars, that our soldiers are coming back with a high rate of the post-traumatic stress syndrome. It's a disorder that is a psychological trauma that affects the physiologic responses, the fight or flight mechanism of the patient, and results in a typical syndrome of high levels of anxiety, nightmares of the incident that caused them to have this stress response. If you think of it as being scared to death, only not dying, you get a picture of the psychological phenomenon that goes on, which starts off the adrenaline response, the fight or flight mechanism that gives us all kinds of physiologic reactions that are very memorable. And they're remembered in the ancient part of your brain, the amygdala, and they're remembered in the more newer part of your memory brain, the hippocampus, and your frontal lobes, which is where we think, are in the business of keeping you away from getting into a traumatic experience again. Any terrible traumatic event, which is an earthquake as an example, being buried under buildings, or being involved in a serious automobile accident, individuals who are sexually abused or who are almost murdered, anything that causes that fight or flight mechanism, you suddenly realize that you're in imminent danger and you experience it both physiologically and psychologically. It's interesting that this is the one clear evidence of a psychological trauma causing brain damage. And we now find that individuals who have had repeated post-traumatic stress phenomenon are showing some wasting of the two memory areas of the brain, particularly the amygdala and perhaps the hippocampus. So we used to talk about psychological trauma not causing physiologic problems. This is where a very severe psychological problem can cause brain injury. You always want to put bad memories in the back of your area and somewhere hiding in your brain somewhere so you don't feel them and getting in the way. And the trouble with post-traumatic stress disorder, it keeps coming forth and keeps coming forth, so people can operate for a little bit, but then when the flashback comes by, one of my veterans patient was sent in for evaluation of PTSD, and we had the helicopter at McKinnon that went by my office window, and he said, well, I was over in Vietnam, I had a kind of a tough time of it, and some of my buddies got blown up and that sort of thing, and just then the helicopter goes by and he dives under my chair, under the desk. I mean, just like that fast. And I said, pardon me, is there something? He says, helicopters do that to me every time. I just dive wherever I can. It just doesn't go away by itself. Time makes it slowly moderate, but most commonly people will get the old bottle out and try to quell their fears and their anxieties by drinking a bunch, and so alcoholism is a big side effect of it. They are frequently irritable and cranky, and so marital discord is common, and marriages break up on the basis of the post-traumatic stress disorder. It's not just a military sort of thing. I mean, war is bad, and so is a lot of other catastrophes. You mentioned earthquakes and things of that nature, and some people have a kind of what we call a Chinese water torture. They have repeated episodes that are not quite as dramatic, but they add up and make a post-traumatic stress disorder phenomenon of that. Ambulance drivers are an example of this sort of thing. They see their first body that's mutilated, and they get a reaction from it, and then they see a couple more and a couple more, and pretty soon they're having dreams of the last time they saw a mutilated body.
Going back through the years, I've had the experience at looking at a number of patients who have what we generally call Alzheimer's disease and other kinder term for it is cognitive decline, meaning that their memory and ability to think and reason starts to deteriorate over time. Most often in elderly folks. It can unfortunately occur sometimes in younger folks. That's the true definition of Alzheimer's disease. And so through my 30 plus years in Miller, I've been able to watch the progression of this process in a number of individuals, many of whom I've known for a long time. And it gives an interesting perspective as to see how they function. And as I say, sometimes when you see them in the exam room at the clinic, you don't always get a full feeling of what, or a full impression of what's actually going on, how they're functioning at home. Are they driving safely? Are they turning the stove off? Are they going out for a walk and getting lost? Those type of things. So we rely a lot on the input of family members, neighbors, interested individuals. I don't know the answer to your question that there's any one single element that truly comes up with the diagnosis, and we're always, to a certain degree, reluctant to hang the diagnosis on folks. But on the other hand, the concern is that if we, wait long enough, that some of the medications used to try and slow the process down may not be as effective if the decision is delayed for whatever reason, either the patient or the physician or whatever the case may be. There tends to be some degree of family history of it, but it can also happen for any number of reasons. There's lots of research going on about it, but just listening to a program the other day about it, they're really considering the number of individuals that this is going to affect in the future as the baby boomers get to the process. It can become quite an expensive disease because those individuals, like we talk about medication used to treat it or to slow the process. But when you look at the cold hard facts, when those folks are unable to care for themselves, that becomes a very expensive process to undertake when they need care either from full-time staff at their house or a nursing home or assisted living types of arrangements. And so in the future it will become a huge element for our nation to try and help fund that process, and number two, especially in rural states like ours, finding the folks to take care of these individuals. There's a number of medications that exist now, prescription medications, and I've become much more liberal myself in starting them early on people and talking over the issue, and just saying that the use of medications can hopefully slow the process down. It doesn't reverse it, but it slows it and allows the individuals to spend more time in their current setting rather than thinking about the fact when they may not be able to care for themselves as well.
Well, that was it. 12 different opinions and CEO, doctors from across the state of South Dakota and a leader of an organization, giving you their perspectives. These people who cared deeply for the people of the state of South Dakota are our friends, and it was a great honor to have them join us. So thank you for joining us as well. Until next time, stay healthy out there, people.
Funding for OnCall is provided in part by
Avera is a proud sponsor of OnCall on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support OnCall, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for OnCall is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.